One of the reasons. Yes.
Dr. Antani sir is joining.
How is Dr. Antani?
Yeah, fine. He is in Pune. He is joining.
Achha.
Yeah, it's 7, sir. We'll start. A very good evening to one and all. I heartily welcome all the members of API, ICP Karnataka and other members of various organizations who have joined virtually from all over the country to attend this program on World Hypertension Day. On this occasion, I welcome Dr. P.S. Shankar, Professor Emeritus RGHS and KBN University Gulbarga, Dr. Muruganathan, past Governor ACP India Chapter, past Dean ICP and the past President of API, currently the Director PRF, who will be joining shortly. Also welcome our own committee members, Patron API, Dr. Maya, Dr. Murali Mohan, Chairman API Karnataka, Dr. Vishwas, Secretary, and Dr. Ravi Kirti and Srinivas Murthy, Central API members. I welcome our today's chief guest, Professor Dr. B.B. Thakur, Patron National API from Muzaffarpur, Bihar. He is the past President API and the past Dean and many other positions held in API. A senior most respected personality in API family, a great researcher, academician, teacher of teachers, loves to teach till now. Received many awards and honors, many publications, both national and international, has special interest in hypertension from decades. I welcome our today's guest speaker, Professor Dr. Venkat S. Ram, Padma Shri Awardee, a world-renowned authority on hypertension, Director of World Hypertension League, Professor of Clinical Medicine, Texas, USA, a great teacher, a scientist, and academician with innumerable publications. In spite of his busy schedule, agreed to send the message on this day, which we are playing shortly. I also welcome our speaker, Professor Dr. P.C. Manoria, Chief Cardiologist from Bhopal, a great teacher, past president of API and CSI, who never said no to any of our invite, that speaks his dedication and passion for teaching and training the youngsters. I also welcome our today's moderator, our own faculty, Professor Dr. Nagaraj Desai, senior cardiologist from Bangalore. I also welcome our today's panelist, Professor Dr. Ashok Kriplani, senior nephrologist from Mumbai, a doyen in the field of nephrology, a great academician and a teacher, received many awards and honors. I also welcome our other panelist, Professor Dr. Upendra Kaul, senior cardiologist from Delhi, Padma Shri Awardee, as he was busy in international program in Paris, returned this morning and joined the program that speaks his affection and commitment of our teaching and training all of us. Let us not waste time by reading their CV profile, which runs in pages. Let us learn and hear from them. As I can see, many have joined virtually from many states of the country, making a national event, which COVID-19 pandemic has taught a new normal life to learn. Lastly, I welcome one and all. Now we have a formal virtual inauguration.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो हरतु मे पापम् सन्ध्यादीपनमोऽस्तु ते शुभं कुरुत्वं कल्याणम्.
Now I request Dr. P.S. Shankar to address and for his introductory remarks.
Dear friends and colleagues, I am happy to welcome a galaxy of distinguished personalities. I am more happy to see Dr. B.B. Thakur, Dr. P.C. Manoria, and my distinguished student, Dr. Nagaraj, amidst us. World Hypertension Day is observed on May 17th every year. It seeks to create awareness around the condition of hypertension that affects more than a billion people worldwide. The World Hypertension League has declared measure your blood pressure accurately, control it, live longer as the World Hypertension Day theme for 2024. Increasing public awareness about hypertension is key, along with access to early detection and management. The objective of the World Hypertension Day is to communicate to the public the importance of the hypertension and its serious medical complications and to provide information on prevention, detection, and treatment. The World Hypertension League launched its first World Hypertension Day on May 14, 2005. Since 2006, the Hypertension League has been dedicating May 17 as every year as World Hypertension Day. Hypertension is among one of the major causes of different health problems such as heart attacks, stroke, kidney-related illness, and even dementia. On the organ damage, Dr. Manoria is going to speak. Hypertension is known as a silent killer as it has no specific symptoms and most suffering from it are not aware till they suffer from a heart attack or a stroke. Several surveys from many countries around the world have pointed out that the public's awareness of their blood pressure levels is very poor, as many of the developing countries transition from infectious to degenerative chronic diseases. The prevalence of hypertension is increasing. At the same time, public awareness of hypertension in these low and middle income countries is quite dismal. World Hypertension Day is organized by the WHO aiming to prevent and control hypertension on a global basis. WHO is an umbrella organization made of 85 national hypertension societies with 8 regional offices. The objective is to promote higher levels of awareness of high blood pressure with accurate measurement of the blood pressure, aiming to control non-communicable diseases caused by hypertension. Hypertension is triggered by different reasons such as genetic, specific medical conditions, and age. It is a lifestyle disease caused by sedentary life with no or little exercise, unhealthy eating habits, smoking, and alcohol consumption. Hypertension is a disease and a major risk factor for premature mortality among the adults across the globe. Demographic transition, rapid unplanned urbanization, and the globalization of unhealthy lifestyles are factors that are escalating the burden of hypertension as well as other non-communicable diseases. We are eager to hear Dr. Manoria on hypertension-mediated organ damage, followed by panel discussion. I am happy to associate myself with the program and I wish all success. Thank you.
Thank you, sir, for your kind words of wisdom. Since Dr. Muruganathan is held up in another meeting, he will be joining shortly and share his comments. Now I request Dr. Murali Mohan sir, our Chairman API Karnataka, for your welcome address.
Thank you for inviting me to be here, sir. It's always great to listen to Professor Manoria. We are honored by the message that is going to be read out by Professor Venkatesh Ram. He's always such an inspiration to all of us. And of course, we always start with many of the doyens here. Professor Shankar always gives us this great introduction. And a very special thanks to Dr. Biradar for inviting and chairing these sessions, organizing these sessions regularly. World Hypertension Day's theme is measure your blood pressure accurately, control it, live longer. And I must add that apart from living longer, control of the blood pressure, control early, enables us to live a better quality of life for whatever years we have. And that, to my mind, is as important as the length of the life. We know that hypertension can affect several target organs, and not controlling it early enough can lead to damage of these organs. And while we are able to extend our life with various measures, with the help of cardiologists, nephrologists, neurologists, and so on, the quality of life begins with control of the blood pressure early, and that really falls into the ambit of the physician and the family physician. So this is an extremely important CME that you've organized, Professor Biradar. Thank you for it. And let me hold you no more. Let's move on with the program. Thank you, sir.
Thank you, sir. Now I request our today's chief guest, Dr. B.B. Thakur, sir, for your inaugural address.
Good evening, friends. I'm delighted to be here, and I thank Dr. Biradar for inviting me to be here with the stalwarts in medicine and my old age friends, Dr. Sankar, Dr. Bhadoria, Dr. Venkatram, Dr. Viswanathan, Dr. Ashok Tripalani, Dr. Nagaraj, and galaxy of friends from different parts of the country. Professor Sankar, as usual, has very nicely briefed about the World Hypertension Day and hypertension. I'm sorry. Few days ago, all of us were observing Mother's Day. I was wondering why Mother's Day on one day only. Mother's Day on all days. Similarly, Hypertension Day on one day is not good. It's as enunciated by Dr. Sankar that friends, I'm sorry, really, I'm sorry. One of my great friends is calling. No problem. So, if we talk of epidemiology, 1 out of 4 or 30% of the people in our country are suffering from hypertension. And if we talk of the senior citizens, super senior citizens, then 3 out of 4. So that is the propensity. And awareness is very poor, not above 20% also. Control is very poor, in spite of the fact that easy to diagnose, easy to control, so many drugs are there. And if we apply our wisdom, then easy also to make the people aware. How many of us are examining the blood pressure of the attendants in our clinic? How many of us will be have been doing the recording of blood pressure in the whole month of May? Are we going to villages? This sort of meeting that we are holding is to educate ourselves only. But we need to educate our masses. For that, we have to go outside. It has been very nicely pointed out by our chairman, Karnataka chapter, that it is not only essential that you control it and live longer, you control it early, to live longer with a quality of life. So that quality of life is also important. And why this situation is there? It is because of inertia amongst ourselves. Apathy towards the masses. If we go into the masses, if we get a meeting at every place of Karnataka, public meeting, socio-political and medical meeting, then possibly we may be able to contain it and control it. Secondly, most of the people are either overeducated or undereducated about hypertension. They will come to you and say, my blood pressure is this level. Google doctor has just spoiled this scenario of medical profession. People go to the Google and they come. I have a patient here. Currently, I'm in Delhi for some work, who is always measuring his blood pressure because somebody has taught him to measure the blood pressure, but not told him that it is not necessary daily. So friends, mostly we are responsible for this apathetic attitude situation. But if we arise awake and start doing, then possibly we may be able to contain diabetes and hypertension, which is incidentally diabetes has come from my mouth. You see, it is hypertension is associated with diabetes, is associated with obesity, is associated with physical inactivity, and it is one of the lipid abnormality, and it is one of the worst diseases that we can imagine because it's a silent and silently it kills. So friends, I'm delighted to be here, and I thank Dr. Brother for having invited me. And I know I'm very confident that this talk, today's meeting, is going to be a wonderful educational program for all of us.
Recording चालू करना.
Thank you very much.
Thank you, sir. Thank you for your kind words of wisdom by sparing your valuable time. In spite you are in Delhi, you have joined. Thank you once again for sparing your time. Now we move on to the scientific session. I request Dr. Nagaraj Desai sir to take over for the further proceedings. Dr. Nagaraj Desai sir. Yeah, since Dr. Venkatraman is held up in the other meeting, we are playing a recorded version of his. We are
Sure.
going to start.
Yeah, Dr. Biradar, why don't we run that Dr. Venkatram's?
Yeah, that's what we are doing. We are playing the same.
Yeah, okay. When it's getting ready, go ahead. Please.
Good morning, ladies and gentlemen. My greetings to all of you who are assembled to signify the importance of high blood pressure in our society in general, and of course for all the citizens in Karnataka in particular. The World Hypertension Day is designated every year in the month of May to increase the awareness of high blood pressure, both amongst the medical community as well as in the lay community, because hypertension is such a powerful risk factor for cardiovascular disease. We need to be reminded about the importance of the World Hypertension Day. And I offer my best wishes to Dr. Sangram Biradar of Gulbarga, who has organized this meeting on the behalf of API as well as on the Indian College of Medicine. He has probably lined up a lot of activities in connection with the World Hypertension Day. And I would ask all of you to follow the theme of this year's World Hypertension Day as much as you can. And in connection with the World Hypertension Day 2024 and the event organized by Dr. Biradar, I am going to cover about 3 aspects of hypertension which are very current and which are very, very important. One, I am going to cover the importance of heart rate in patients with hypertension. Then I am going to cover the importance of isolated hypertension in the elderly, healthy elderly, and patients who are frail elderly. And thirdly, I am going to cover very briefly about a new class of drugs approved by US FDA in the month of March, namely endothelin antagonist in the treatment of hypertension. These three things, ladies and gentlemen, I am going to cover, and I hope the information that I'm going to give will be useful in managing hypertension in your practice. So let us go on with the formal presentation that I have created for your benefit today. Good afternoon, ladies and gentlemen. Now, let me talk about a few things related to hypertension very, very quickly. I'll cover several points. The theme of the World Hypertension Day, shown on this slide, is measure your blood pressure accurately, control it, and live longer. And this is the theme for this year's World Hypertension Day. This is a slide showing the burden of cardiovascular disease in India that is imposed by hypertension. You will notice that in 25 years, there has been almost doubling of cardiovascular disease attributable to hypertension in India, and it is an important finding to keep in mind. The financial burden from cardiovascular disease in India is enormous, as you can see on this slide. A large amount of money is spent on management of complications related to hypertension, complications on the brain, the heart, the kidney, etc. So the annual expenditure is just a phenomenal to take care of patients who have complications as a result of uncontrolled, untreated, and undiagnosed hypertension. A large number of deaths from stroke and cardiovascular disease are directly related to elevated blood pressure in our community. You will notice that the cardiovascular disease is actually declining in many parts of the world, except in our region, South Asia region, where the cardiovascular disease is increasing, just the opposite of what is happening in the rest of the world. You are quite familiar that by treating hypertension, you reduce the risk of all complications, but in particular, the risk of coronary heart disease and stroke is significantly decreased when you lower the blood pressure. So when you treat hypertension, ladies and gentlemen, you're not only lowering the numbers, but you're also lowering the risk of various complications such as coronary heart disease and stroke in our country. Now, this is now well known that any blood pressure that is more than 130 or 80 is detrimental to health. It doesn't matter how you define hypertension, but the goal blood pressure should always be close to 130 by 80. Whatever classification of hypertension you use, keep in mind the ultimate goal, objective, is to achieve a blood pressure close to 130 by 80, and that should be maintained in your clinical practices. And that is the reason why today, the World Hypertension Day, we have to think about the objectives of treating hypertension is blood pressure close to 130 by 80. What I'm going to cover is things that are not usually covered in relationship to hypertension. One aspect that you have to keep in mind is that heart rate is an important prognostic factor for cardiovascular disease in general, but more so in patients with hypertension. We don't measure the heart rate or pulse rate in clinical practice unless the patients complain of palpitations. So, ladies and gentlemen, please remind yourselves that heart rate is a very important prognostic factor for cardiovascular health. So when you record heart rate, or let us say pulse rate, it is a very important parameter to put it in patient's record, because any increase in heart rate is going to be detrimental in the long run, and I'll show you the data. So one aspect that I'm going to cover today is the importance of heart rate as a prognostic factor. Heart rate has been associated with the entire continuum of cardiovascular disease, from cardiovascular risk factors to cardiovascular disease to complications and to end-stage heart disease, end-stage kidney disease. In all these conditions, an increase in heart rate plays an important role in promoting the progression of cardiovascular disease. This is very easy to understand. Whenever there is increase in heart rate, there is increase in oxygen demand, but when oxygen supply is limited as a result of coronary or general vascular disease, it is going to cause myocardial ischemia. So an increase in heart rate has a detrimental effect on myocardial perfusion, and that is the reason why you should never allow the patients to have resting tachycardia for too long. You need to pay attention to the heart rate as an independent and important contributing factor for cardiovascular health and disease. These are the studies which have looked at high heart rate versus normal heart rate. All these studies have concluded that those individuals who have high heart rate have adverse prognosis in terms of increased cardiovascular mortality compared to those who have normal heart rate. So there is abundant evidence that persistent tachycardia is a poor prognostic factor. This is from the Framingham study, both in men and women. You will notice the mortality rate is quite high. All-cause mortality is quite high based upon the heart rate. Higher the heart rate, higher the mortality. Lower the heart rate, lower the mortality. And in fact, it has been calculated from European countries, both short-term or long-term mortality. You will notice heart rate is a significant factor in contributing to mortality, like age, tobacco, etc. Heart rate by itself is a predictor of mortality. And there is also a relationship between diabetes, hypertension, and heart rate. And this is a study that was done in US looking at insulin resistance and heart rate. You will notice those individuals who had high heart rate had high insulin resistance compared to those who have normal heart rate. So ladies and gentlemen, there is a connection now between, not now, but always, between the heart rate and insulin resistance and diabetes. And this is a relationship between the resting heart rate and cardiovascular death in patients with diabetes. You will notice those patients who have diabetes, who have increased heart rate, they have a higher risk of cardiovascular death compared to those who have normal heart rate. So again, I'm putting the things together, that heart rate and cardiovascular prognosis, heart rate and insulin resistance, heart rate and prognosis in diabetic individuals. Now, this is very interesting. The prognostic indication of heart rate is as much as that of left ventricular hypertrophy. And this is a multivariate analysis looking at heart rate and coronary and atherosclerosis. So you see here, heart rate is put almost in the same category as left ventricular hypertrophy. So as a clinician, if you see somebody who has got tachycardia, it is as bad as somebody is having left ventricular hypertrophy. This is an experimental study looking at atherosclerosis in animals with high heart rate compared to low heart rate. You will notice those animals, namely monkeys in these instances, have high risk of atherosclerosis in the presence of tachycardia. In the presence of normal heart rate, then the atherosclerotic burden is reduced. This is a study looking at heart rate as a predictor of coronary events. Every 5 beats of increase in heart rate increases the risk of coronary heart disease by 14%. And you will notice here, as the heart rate increases, the coronary events also increase. So there is a relationship between heart rate and coronary heart disease, very important to keep in mind. So, ladies and gentlemen, what I have done now is I have put heart rate in the same category as hyperlipidemia, as diabetes, as obesity, and as glucose intolerance. So I have put heart rate as a risk factor along with all these conventional risk factors. Beta blockers in general have been shown to decrease heart rate in patients with hypertension and in patients with coronary artery disease and in patients with congestive heart failure. So beta blockers have been shown to decrease mortality in patients with coronary artery disease, and there has been a connection between heart rate and prognosis from myocardial infarction. This is a study with a cardioselective beta blocker, bisoprolol, in the doses of 2.5 to 5 milligram. You will notice when you give bisoprolol, there is a reduction in blood pressure, but there is also a reduction in the heart rate. So that should be the goal in the treatment of hypertension. When you treat hypertension, you have to not only reduce the blood pressure, but you also have to make sure that heart rate is normal. If the patients have tachycardia, it has to be decreased. So this is an important slide, the hemodynamic effect of beta blockers in reducing the blood pressure and reducing the heart rate, which is very important as shown in the next slide. This is a slide looking at the relationship between the blood pressure and heart rate. You will notice the best prognosis shown in the green color is those who have blood pressure that is controlled and who have low heart rate. But on the other hand, if you have blood pressure that is controlled and have high heart rate, the risk is still higher. So the best way to reduce cardiovascular events in patients with hypertension, as shown in the green color, is to reduce both the blood pressure and the heart rate. Both of them have in order to bestow good prognosis to patients with hypertension. So, ladies and gentlemen, now I have covered so far heart rate in the same category as other risk factors for cardiovascular disease. And now let us move on to another topic of interest for all of us, namely hypertension in the elderly and very elderly. All studies have shown as we get older, there is increased risk of stroke and heart disease, mainly due to increase in blood pressure. And this is a study done in basically meta-analysis from a large number of studies looking at a relationship between the blood pressure, the age, and ischemic heart disease and stroke. And there is a connection. As we get older, there is high blood pressure, and there is also high risk of stroke and ischemic heart disease. As we get older, it is a systolic blood pressure that goes up much more rapidly than diastolic blood pressure due to vascular stiffness or arterial calcinosis. So many elderly patients, not all, but many elderly patients have disproportionate systolic hypertension compared to other age groups because of arterial stiffness and also due to arterial calcinosis. Isolated systolic hypertension is a major risk factor for cardiovascular disease and cardiovascular death. And this is from the Framingham study looking at normal blood pressure versus isolated systolic hypertension. You will notice once you have isolated systolic hypertension, your risk almost doubles of cardiovascular disease and of cardiovascular mortality. Fortunately, when you treat hypertension in the elderly, you can decrease the cardiovascular events. And this is from the SHUP trial, looking at the effects of treatment on complications of hypertension in elderly patients. You will notice by treating isolated systolic hypertension, you reduce the risk of stroke, heart disease, congestive heart failure, composite cardiovascular disease, and mortality. All these complications are significantly decreased when you treat systolic hypertension in the elderly. And this is a similar trial from Europe called SYSTUDE trial, where once again, treatment of hypertension has been shown to decrease all cardiovascular complications in the elderly. So, ladies and gentlemen, what I have shown so far that isolated systolic hypertension is a major risk factor for premature cardiovascular disease in the elderly. But I also have shown that treatment of hypertension in the elderly can decrease the risk of morbidity and mortality. And this is one study which is called STEP trial, which has again shown that when you treat elderly hypertension aggressively, shown in the orange color, you decrease the risk of complications. One more trial to suggest that the target blood pressure in the elderly should be a little bit more aggressive than what you're used to in the past. Hypertension in the very elderly, called HYVET. This was a study done in patients older than 80 years of age. And when the blood pressure was reduced in these patients older than 80 years of age, there was a significant reduction in stroke and heart failure. The last study that looked at the elderly is the SPRINT trial, where in the SPRINT trial, elderly patients were also treated. And you will notice when elderly patients were treated, all the cardiovascular complications, especially dementia, was significantly decreased. So all these trials do suggest by treating hypertension in the elderly, there are enormous benefits of reducing cardiovascular disease as well as improving cognitive function. This is the meta-analysis of treating hypertension in the elderly. When you treat hypertension in the elderly in a proper fashion, you actually decrease the risk of stroke by 20%, reduce the risk of stroke, myocardial infarction by 15%, and cardiovascular mortality by 18%. Now, this is the meta-analysis of treating hypertension in the very old people, older than age 80. You will notice that when you treat very old people, older than 80, you reduce the risk of stroke, heart disease, and congestive heart failure. And of course, not surprisingly, you don't see much effect in mortality because they're already at high risk. But very important to keep in mind that you can maintain the independence of the elderly when you decrease the risk of stroke, coronary heart disease, and congestive heart failure, even in people older than 80 years of age. So these are all the benefits of treating hypertension in the elderly. Now, there are also some risks that are associated with treating hypertension in the elderly that I'm going to discuss now. Various guidelines talk about hypertension in the elderly, but very few guidelines actually talk about the risk of treating hypertension in the elderly. Many guidelines suggest the blood pressure in the elderly should be less than 140/90. But they don't define whether the same goal should be applied to those who have pre-existing orthostatic hypotension. So let us say you have an elderly patient who has orthostatic hypotension. Should we achieve the same goal as those who don't have orthostatic hypotension? Very important point that is not discussed in the elderly is what is the goal of treating hypertension in the elderly if they already have pre-existing orthostatic hypotension. And let me take you to the next slide. This is something that I have assembled. I suggested that if in the elderly, if the standing blood pressure falls by more than 20 millimeters, maybe you should use postural blood pressure as a target, not supine blood pressure. In other words, an elderly patient who has orthostatic hypotension and the systolic blood pressure falls to more than 20 millimeters, maybe you should use standing blood pressure as a therapeutic target and not the supine blood pressure. There are some complications of treating hypertension in the elderly, and this is from the SPRINT study. In the SPRINT study, the risk of renal impairment or kidney injury was more in the aggressively treated group. You will notice in this study that patients who had aggressive treatment of hypertension, they had a higher risk of developing renal impairment, and you have to keep this in mind. This is a very interesting analysis of hypertension in the elderly, very interesting study. When you treat elderly, if you achieve a blood pressure less than 130 with fewer medication, their prognosis is very good. But if you achieve a systolic blood pressure less than 130 and the patient is requiring multiple antihypertensive drugs, then their prognosis is not that good. That only suggests that those patients who are requiring multiple antihypertensive drugs, they probably have extensive cardiovascular disease. So if we can treat systolic blood pressure to a goal of 130 with fewer antihypertensive drugs, their prognosis is better than when you are giving multiple or several antihypertensive drugs. So let me conclude then. There are two types of elderly that you see in clinical practice. There is an elderly person who is not frail, who is quite independent, who is walking, talking, etc. And there is another elderly person, same age, same blood pressure, but who is very frail, who may have motor skeletal disorders, who may have cognitive dysfunction, who may have arthritis, who may have movement disorders. When you treat hypertension in the very frail, the benefits are not there because the complication rate of cardiovascular events in the elderly person who is frail is much higher than somebody who is not frail. So one take-home message is, when you're talking about hypertension in the elderly, you have to make a distinction with the hypertension in the elderly in a person who is not frail or who is frail, because the prognosis is quite different in these two categories. So you have to look at the benefit versus harm of treating hypertension in the elderly. The harm could be you might precipitate postural hypotension, you may precipitate syncope, you may precipitate renal failure, but the benefits are you reduce cardiovascular mortality, reduce heart failure. So you have to weigh the benefit versus risk based upon the patient's prognosis, cognitive impairment, and whether the patient is frail or not. So ladies and gentlemen, what I have done is I have covered the importance of treating hypertension in the elderly. At the same time, I also have covered the benefit versus the risk of treating hypertension in the elderly very aggressively. The last segment that I'm going to discuss is in the recently in March of this year, the US Food and Drug Administration have approved an endothelin receptor antagonist called aprocitentan for patients with resistant hypertension. This particular drug, aprocitentan, has been used in patients with resistant hypertension, and it has shown to be very successful. And this is a new category of drugs that has been approved by the Food and Drug Administration recently. But for the time being, it is for patients with resistant hypertension. Endothelin receptors are very important in causing vasospasm. There are two receptors. One is endothelin A and endothelin B. When you block both endothelin A and endothelin B, it causes vasodilatation. So the endothelin receptor antagonists have to be dual endothelin antagonists that block endothelin A as well as endothelin B. And actually, I had written about the endothelin antagonists in cardiovascular disease more than 20 years ago, 21 years ago. Now, I have written again on this drug that is going to be published in the next few days in American Journal of Medicine on this class of drugs. So, ladies and gentlemen, in my own lifetime, it took almost more than 20 years from the concept to application. The concept was there when I wrote about it. I did not know that in our own lifetime, you will have the approval of a new class of drugs, endothelin antagonists, for the treatment of hypertension. And this is the slide that I'm going to show, on the basis of which the Food and Drug Administration approved the aprocitentan for the treatment of resistant hypertension. You will notice that by giving this dual endothelin receptor antagonist, there was a significant fall in systolic and diastolic blood pressure. And that is the reason why the drug has been approved for resistant hypertension in US. I do not know what the plans are for endothelin receptor antagonists in India. So let me conclude, ladies and gentlemen, in the time that was allocated to me to give a kind of a narrative or a trove of Hypertension 2024. I covered on the importance of heart rate. I covered on the importance of systolic hypertension, and I made a distinction between hypertension in the elderly, in those who are healthy and who are frail. And finally, I covered a new class of drugs that has been approved in US for treatment of resistant hypertension, namely endothelin antagonists. I hope the information that I have given will be useful in your clinical practices. But let us then conclude my talk by stating the theme of this year's World Hypertension Day, namely to measure the blood pressure accurately, to control it, and so that you can live longer. And this is what you should apply in your clinical practice for the benefit of the society at large and for the benefit of the country in general. Ladies and gentlemen, thank you very much.
Thank you. Thank you so much, Professor Venkatram, for that very elegant discussion on hypertension as usual. And when we decide to control high blood pressure, it looks like we require to learn beyond blood pressure readings alone. And blood pressure mediated target organ damage evaluation becomes an important aspect of care of patients with hypertension. We could not have had a better person to deal with this topic, Dr. P.C. Manoria from Bhopal, a mentor of mine in the past and also a very good friend. And he's going to discuss how he wants to evaluate in the modern times the target organ evaluation in a patient with hypertension. Dr. Manoria, please.
Are you able to hear me?
Yep,
Yes.
go ahead, sir. Thank you.
At the outset, I'd like to thank the API Karnataka chapter for inviting me to this wonderful program on World Hypertension Day. Dr. Sangram, Dr. Murli Mohan, and other dignitaries. So for the next 20 minutes or so, I'll be talking on hypertension-mediated organ disease, which is commonly termed as HMOD. The last couple of years has witnessed spectacular advances in the field of HMOD, both in terms of enhanced understanding and in the availability of a panoply of new therapeutic options. When we look at the heart, all of us know HFpEF is not uncommon in hypertensive patients, and we have SGLT2 inhibitors as class 1 recommendation for treatment of HFpEF. And very exciting data has emerged from injectable semaglutide in the HYPERTENSION trial, not only improving the quality of life, the walking distance, but also cardiovascular outcome. So in times to come, I'm sure injectable semaglutide will also emerge as a new drug for treatment of HFpEF. Of course, HFrEF is uncommon in hypertension, usually occurs with CKD when there's volume overload, and then of course the usual drugs for HFrEF would apply. In the context of kidney, which is very, very important, and we like to learn from Dr. Kriplani, we have three revolutionary therapies. RAS blockers, all of us are aware of it. Then came SGLT2 inhibitors, and now we have the third revolutionary therapy, non-steroidal MRAs, that is finerenone. And in recent past, the FLOW trial has been positive. So in times to come, you will also have GLP-1 receptor agonist semaglutide added to the pillars of CKD. In context of brain, we have lytic therapy for ischemic stroke, which is now being increasingly utilized in endovascular therapy. And in peripheral arterial disease and also stroke, a new concept of DPI, dual pathway inhibitor, aspirin plus rivaroxaban, particularly in peripheral arterial disease, has shown exciting results, and we have seen patients with threatening gangrene or intermittent claudication, there is immense benefit. Retinopathy is not my domain, so I'll not be much talking about it. Now, the message is very clear, and it's the old message, hypertension is a silent killer. But the message which is not percolated widely among the physicians and the practitioners is target organ involvement also continue to remain silent for a very, very long time. You may have severe CKD, you may have left ventricular hypertrophy, another target organ damage, and you may be totally asymptomatic doing your routine work. And this slide must be widely disseminated, which shows asymptomatic organ damage. And one of the most important symptomatic target organ damage is microalbuminuria. 30, 0 to 30 is normal, 30 to 300 is micro, and above 300 is macro. You may have microalbuminuria, you may have macroalbuminuria, you may not be symptomatic always. CKD, GFR less 30 to 60, ankle brachial index less than 0.9, carotid femoral pulse rate velocity more than 10 meters per second, carotid plaque or ECG or echo evidence of LVH, and a pulse pressure of more than 60 in elderly. So we must also realize that organ damage may also be totally asymptomatic, and that's why periodic evaluation of hypertensive patient is very, very important. When we are talking of the target organ damage or hypertensive mediated organic disease, we must adopt a holistic approach for treating hypertension, not only the office blood pressure, but the whole 24 hours blood pressure should be targeted, the nocturnal blood pressure, the blood pressure variability, the morning surges, all should be targeted. So when we talk of kidney in hypertension, this is very, very important organ which is affected by kidney, and a lot of things can be done. You can slow down the trajectory of CKD if you diagnose CKD at a very early stage, and we learn from Dr. Kriplani. Now, in the context of CD, what is very important to realize is that CKD is a progressive disease. We do not have any quick fix to reverse CKD. Once CKD sets in, it is a progressive disease. Unlike acute myocardial infarction, you can do a primary angioplasty and reverse the pathophysiological process. For CKD, we can only slow down the trajectory of CKD, slow down the declining EGFR, and postpone dialysis by 10 or 15 years. And we have three revolutionary therapies. RAS blockers, which came in 2001 after these landmark trials, IDNT renal, SGLT2 inhibitor, these three landmark trials, all of us are aware, and the non-steroidal MRAs, Fidelio, DKD, Figario, DKD, Fidelity. RAS blockers and SGLT can be utilized in both diabetic and non-diabetic CKD, but we have trials with finerenone only in diabetic CKD, non-diabetic CKD, the trials are in progress. So the big message, rather the biggest message for HMOD kidney in hypertension is diagnose CKD at a very early stage for maximum benefit of the revolutionary therapies. And for this, you have to get an EGFR and albuminuria. And what is very important is that ACR is a better predictor of cardiovascular mortality across the full range of renal function. Here you can see UACR, even when it is a normal range, 0 to 30, you can see the hazard ratio at 30 is some 1.77. So even when it is in the normal range, your cardiovascular mortality hazard ratio at the margin of 30 is increased, and then it goes on increasing. Whereas with if you are estimating EGFR, only when the EGFR becomes less than 60, there's an increase in the cardiovascular mortality. So both these parameters must be evaluated, and all guidelines recommend that all these parameters must be, both these parameters must be evaluated. And you can see even if your EGFR is more than 90, and if you have macroalbuminuria, you fall in the high risk zone. So UACR is a biomarker not only for renal disease, but also for cardiovascular disease. Even in the microalbuminuria range, you can have a cardiovascular disease. In fact, microalbuminuria is a red signal for the cardiologist, a red flag for the cardiologist, and he must utilize all his therapy to minimize cardiovascular disease. And cardiovascular disease, all of us know, is a commonest cause of morbidity and mortality in CKD. But there's a lot of lack of awareness for doing UACR amongst the physicians, the practitioners, and this should be periodically done if you are diabetic, hypertensive, if you are in the microalbuminuria, maybe twice in a year. For several years, we have been chasing BP target, LDL target, glucose target, 90 pro-BNP target, but time has come. You must also chase the UACR target. We must utilize UACR as an additional target, both for cardiac as well as renal protection. And the goal is to reduce the UACR by more than 30% if it is more than 300. And this is a guideline based. And if it is reduced by more than 30%, you try to reduce it further. And these are the three established pillars of CKD, the RASI, the SGLT2 and MRAs. And now after the flow trial, which has been prematurely terminated, in times to come, you may have the fourth pillar with semaglutide. Heart in hypertension, heart again is a very important target organ which is afflicted by hypertension, and you can see you can have LVH, fibrosis, which I'll be talking about, diastolic dysfunction, HFrEF, or a CAD angina or acute myocardial infarction. Left ventricular hypertrophy in hypertension, the extent is predominantly related to the duration of hypertension, the level of increased blood pressure. Initially, it occurs as a compensatory process representing an adaptation to ventricular wall stress, but several other factors are involved besides the hypertension: increased sympathetic activity, RAS activation, salt intake, and some genetic predisposition. And if you have left ventricular hypertrophy, 2 to 4% higher risk of cardiovascular event, increased to cognitive impairment, AF, ventricular arrhythmia, sudden cardiac death, diastolic dysfunction, HFpEF, and HFrEF, particularly of CKD. Regression of left ventricular hypertrophy, RAS blockers, ACE/ARB are more effective, and regression results in reduction in cardiovascular events, heart failure, AF, and it has a better prognosis. How do we evaluate? I think all of us are aware of it. ECG, echo, and these days LGCMR is used to detect fibrosis because a hypertrophic fibrotic ventricle is bad than a merely hypertrophic ventricle, as I'll be talking in a couple of minutes. Evaluation by ECG, I think all of us are aware of the voltage criteria. Sometimes you can use a non-voltage criteria, usually ECG. Sometimes you get low voltage in the limb leads, but LVH in the precordial leads because there is edema in the limb leads because of heart failure. So, and this again, sometimes people want to differentiate whether the ST changes in left ventricular hypertrophy is because of strain or is it because of a coronary artery disease. And these are some of the points. If you look at the J point, with a pressure over the LVH, you can see the J point is depressed. Whereas in ischemic injury, J point is not depressed. ST segment is downsloping in left ventricular hypertrophy strain, is horizontal. T third wave inversion is asymmetrical. You can see this is asymmetrical, whereas a symmetrical terminal part of T overshoots in left ventricular strain, you can see what is isoelectric no overshoot. So these are some differences for those. Serrations in the upstroke of the QRS or downstroke is indicator of fibrosis, but this is not a very sensitive. It is LGECMR, which is a very sensitive test for fibrosis, and I'll be talking to you very shortly. Now, echocardiography, I think all of us are aware of. How do we make a diagnosis of left ventricular hypertrophy by LV mass? And I'm not going to detail. Now, what is important is whether you have a concentric hypertrophy, whether you have an eccentric hypertrophy. This has prognostic importance. Eccentric means your LV wall thickness is normal, but cavity size is increased, your LV mass is increased, and concentric means thickness is increased, cavity size may be decreased, and LV mass is increased. Now, this is important now. So if you have a concentric and dilated LV like this, the patient survival is worst. Compared to concentric without dilatation, comparatively better. And if you have an eccentric hypertrophy, if it is non-dilated, is better than it is dilated. So that is the importance to differentiate these types. And this is the usual picture. I think all of us are very familiar. Transmitral Doppler, I think all of us are also familiar about these patterns, the normal, the impaired relaxation, the restrictive pattern, and I'm not going into the details, and the E by E prime ratio more than 15 becomes abnormal. And this again summarizes the various echo features of diagnosing HFpEF, which means you have to have evidence of heart failure, a structural heart disease, LVH, LA enlargement, or left atrial volume index, increase in BNP, more than 35 in sinus rhythm, or more than 125 NT-proBNP, and you can measure the left atrial volume index, E by prime ratio more than 14, pulmonary artery hypertension, left ventricular mass index, and tricuspid velocity increased. Now, this is a new concept. How do we evaluate fibrosis? Fibrosis in hypertensive patients occurs in the heart, it occurs in the left atrium, also in the vessel, the larger arteries as well as small, and I'll show you some data. Now, this is a slide which shows these small white dots. If you have a fibrosis in a hypertrophic ventricle, fibrosis predisposes the patient to development of heart failure. Fibrosis predisposes to the patient of developing ventricular arrhythmias. For example, in all hypertrophic ventricle, for example, HOCM, we look at the scarring or fibrosis by MR. More is the fibrosis, more are chances of ventricular arrhythmia and sudden cardiac death. In advanced centers who do aortic valve replacement, they always look at whether the hypertrophic ventricle of aortic stenosis also is fibrosis. If it is fibrosis, the result may be less optimum despite an excellent aortic valve replacement. Fibrosis also occurs in the left atrium. You can see these grades of fibrosis, and once the left atrial is fibrosed, this is an additional predisposition for development of atrial fibrillation. And if you have advanced fibrosis, grade C and D, the radiofrequency ablation which is done by the cardiologist, he always looks at left atrial fibrosis. If it is advanced, the probability of sustaining rhythm, sinus rhythm after RA ablation is very remote. So that is another applied importance. Fibrosis also occurs in the large vessel. I will talk. So another complication is angina. You can have an epicardial coronary artery disease, which is easily diagnosed. Microvascular has some problems. Angina could be due to increased demand or a combination. Now, this is the story of a 42 years old male, chest pain on exertion, TMT positive, angina on effort, coronary angiogram done at other hospital 2 years back, no CAD. He was dismissed. You don't have coronary artery disease. Somebody did tell him and said, don't have any coronary artery disease, consult a gastroenterologist, consult a psychiatrist. Patient continue to have symptoms with no relief. He came to us, we did an angiogram, and you can see this slow dye is taking a lot of time to clear the epicardial arteries. And this is the simplest test for microvascular dysfunction. If you want to categorize or document microvascular dysfunction, you can do CFR. If CFR is less than that, 2, it becomes microvascular disease. But this is more expensive. You can get it from PET. So this is the simple way. The patient was prescribed anti-anginal drugs and he became real symptomatic. What is very important to remember is stress thallium will be normal in microvascular disease. The other importance of microvascular disease, which is not uncommon in hypertensive patients and also in diabetic, that if you perform an angioplasty and if a patient has distal microvascular disease, the results are going to be suboptimal, and paradoxically, it may also increase angina on some occasion. So detecting a microvascular disease in a patient with an epicardial disease is also important, and this is one of the simplest way. Otherwise, there are various tests to detect microvascular dysfunction. And as we said, CFR is the best, but that is not easily available. And angina in hypertensive patient could be due to increased demand also, because the left ventricle is hypertrophy, there's increased demand, coronary may be normal, still you can have a positive test, or it could be increased oxygen demand due to hypertrophied ventricle. So sometimes you have a positive stress test, young patient, you find the angio is normal, the reason is this. Vasculopathy, which occurs in larger arteries, small artery, we evaluate by pulse wave velocity, CIMT, ankle brachial index, and retinopathy for the ophthalmologist. You can calculate the pulse wave velocity, and this is to illustrate what happens if the pulse wave velocity is changed. Now, this is a compliant artery of a normal individual, pulse wave velocity 8 meters per second. The impulse goes from the heart to the aorta. You can see slowly when it goes from the heart towards the periphery. By the time it comes back slowly, the systole has finished and diastole has set in. And this increases the diastolic flow in the coronary arteries and is beneficial. But if you have an aortopathy, fibrosis is less compliant, the pulse wave velocity may increase, maybe 12 meters. What will happen? If you measure the pulse wave velocity, this comes back very quickly. So by the time it comes back, systole is already ongoing. And if this happens, it will increase the central systolic pressure, increase the LV afterload, increase pulsatile strain, plaque rupture may occur, no diastolic augmentation, and even decrease coronary filling. And aortic stiffness, all of us know, is an important risk prediction of cardiovascular events. And by periscope, you can find out all these parameters. It will give you brachial ankle pulse wave velocity. It will give you carotid femoral pulse wave. You can also have an idea about the central aortic pressure. And you can get all these very easily from the periscope. Ankle brachial index, all of us are familiar of. It is less than 0.90. This means peripheral arterial disease. If it is 1 to 1.4, if it is normal, but the patient has symptoms, do an exercise test. If it is borderline 0.91 to 0.9, borderline PAD, exercise ABI is recommended. CIMT is also performed by some, and the usual CIMT is 0.8. If it is increased more than 1, it is a predictor of cardiovascular events. So you can see if it is more than 1, this is a high incidence of cardiovascular events. And both these parameters, CIMT or pulse wave velocity, are important prognostic and predictive factors. And these days, MRI is also used by the radio to assess the aortic distensibility. And this is the data from sprint test, which shows that those patients whose pulse wave velocity has decreased following NTI, which means you have two patients similar, say 160 by 100. In one, the pulse wave velocity decrease. This has a better outcome compared to the. So decrease in pulse wave velocity is a better predictor of a favorable response. I think brain and hypertension, all of us are aware of it, and not like to, and if you can evaluate the carotids or the body vessel by the carotid vascular ultrasound or by CT or MR angiograph or CT or MR in those patients who have developed strokes. Retinopathy, of course, is not our domain, so I'll not be touching, but it's important. You can see all physicians must also look at the fundus. So again, I like to reiterate, target organ damage involvement also remains silent for a very long time, and this slide is wide dissemination. The problem with hypertension is not only the number of blood pressure which matters, the associated risk factors, the associated comorbidities are also important in determining the prognosis of the patient and initiating treatment. So to our patients, we give this mobile number for simplicity, 13080-10070, so they can see in the mobile. For blood pressure, there should be 130 for systolic, 80 for diastolic. For LDL, less than 100. These days, less than 70. For HbA1c, 7, and for smoking is 0. And this slide is dedicated to the President API Karnataka chapter, Dr. Murali. The treatment of hypertension is a long drawn out process over the years, and therefore special emphasis should be laid on the quality of life, We must never forget our hypertensive patient not only live but also feel well, and this is very, very important. And most of the hypertensive patients are asymptomatic. It's very difficult to make an asymptomatic individual feel better. Usually is made worse. So very careful selection of drugs. I think that's all. Thank you very much for your kind attention.
Thank you, Dr. Manoria, for that wonderful deliberation on the way in which we evaluate the target organs and the implications of the presence of target organ damage, and what are the steps you would be considering in the managing these patients with the hypertension. May I request if the nephrology colleague of ours is free and to join?
I'd like to know this vascular calcification, which you commonly see, resistant hypertension, CKD, what is all this and how can we tackle all this? Because we often hear from the nephrologist, we want to know
Yes.
preliminary information.
Sure, definitely. I think he must be available. In the meantime,
Yes.
Dr.
Yes,
Murli congratulates you from Bangalore, saying that it is an excellent presentation. I also felt so. Thank you so much. And
Yeah,
let's,
Dr. Kriplani sir is there. He's there.
Dr. Kriplani, sir, please kindly join us and then start
He's
your.
there, he's there.
Yeah, good evening, everyone. Thank you for inviting me. And it's a very big day when hypertension is remembered. It should be remembered every day. But I must congratulate the API Karnataka and the API team for putting this up, and two brilliant talks, both by Dr. Venkatram and Dr. Manoria, have highlighted the renal aspects. So they've made it easy for me to make comments. So to first answer the question that Professor Manoria has put about this calcification. You see, other than the usual cholesterol and lipid factors which affect the intima, we have factors other than that due to the hyperparathyroidism, which we call CKD, MBD, metabolic bone disease, and cardiac disease, where there is, because of the parathormone and calcium interactions and hyperparathyroidism, there is deposition of calcium extraosseously into the coronaries and all other vessels. And that type of coronary calcification is different. It is not only not in the intima, it is in the media and of the arteries, and it is long calcification. So our cardiology colleagues who do stenting and cardiology surgeons who do the bypass will tell us that is very difficult because the segments are long. They are not short nips as they are seen in the cardiac patient with no CKD, but with hyperlipidemia and pure hypertension. So the whole problem of restricting this calcification all over the body, including the radial, etc., when we try to put fistula, is dependent on how we manage the calcium part of the CKD MBD and respond by reducing the parathormone and keeping this extra osseous calcification under control. So it's very important for us to do that well, so that when the patient progressives, and that should be in CKD stage 3, A, B, and 4, because that is what progresses later and hampers the transplant and the looking after of the patient and causes premature death in the patients of CKD because of coronary artery disease. In fact, there is so much now emphasis on saving the patient's heart and not worrying too much about the kidneys. So if I may say, the new guidelines from our renal association, the KDIGO and the KDOKI, they are all focusing more on heart care rather than on kidney care. Now, Dr. Venkatram very nicely mentioned that the target for CKD is lower than the target for others. And somehow it has become a very important part to the nephrologist to protect the heart. So this 120 by 70 or 75, which is the target being invited as the better target, is not really to protect the heart. So Dr. Venkatram makes a very valid point that when you try to reach that target, the J-shaped curve does kick in, and many of the patients will lose GFR even in trying to protect the heart. And yet all the bodies who control nephrology are now accepting the cardiologist, especially because of the sprint trial. Now, the fallacy there is, and when we actually do it and try to reach 120, a lot of the patients who are not old, who are 50, 45, 60, waiting for transplants, they land up getting a rapid increase in the creatinine after we reach the target. So about this target, I would like to say that that target is valid as the sprint method. The sprint method used not the single office BP, but the what we call the BP true or the Omron 970, which measures out of office BP equivalent in the office. And this is very important. This is a unobserved method of tying the blood pressure instrument in a quiet room, checking the first reading by SSC or HSC qualified nurse who goes away, and then automated office BP, which was originally started in Canada and then has come on to this Omron 970, is a brilliant way of finding out a surrogate of the ABPM in the daytime. And many data have shown, because it's not possible, the gold standard is of course to do the ABPM, but it's not physically possible to do everybody's ABPM. But when the patient comes to office, one should remember that one office reading is useless. It has to be done in this unobserved method, automated, and get an average of 5 or 3, or now the MicroLife is brought out an instrument which even can be used at home by the patient to get an average of 3 readings at half minute. And these are all being validated as being surrogates of the daytime average BP. And that is the target of 120 by 75, which these sprint are asking us to use. Of course, let me say there are big limitations to sprint findings, and more are being now becoming obvious. That sprint sub-analysis has shown that the creatinines tend to increase when we go to this target. So we try to protect the heart, and we see little more rapid increase in creatinine, but we prevent the patient from dying from heart attacks due to this severe calcification of arteries. I hope that summarizes what you would like me to tell you.
Any drug for minimizing calcification?
Well, sir, drugs are plenty, but using the drugs like cinacalcet, which works on the calcium sensing receptors, these are now being used very well to protect and prevent these calcifications. But the most important thing is frequent checking and adjustment with alkaline phosphatase, bone alkaline phosphatase, and FGF23, which markers are still to be adopted so popularly because of their cost. And when these markers are adopted, we will get a better way of adjusting and getting the calcium to the target we want. And there are many pitfalls in that, which I can't elaborate, but certainly those who see the patient frequently and keep a watch on the IPTH rather than the calcium, keeping the IPTH not normal value 75, but twice the normal, that is 150, is a good target. And keeping the calcium in ionized calcium form to about less than 5, between 4.5 to 5. These are the more useful targets, which will help us with the use of calcitriol and cinacalcet to come into the mainstream management of these patients. And that protects the patient from heart disease and this very severe calcification which kills the patient. Also, the hypertension, which I didn't elaborate on, you have very nicely shown the hypertension as a cause of modulation of the LVH going on to concentrate LVH, then dilatation, then eccentric LVH, and then of course leaking valves. Once the valves start to leak, it's a terrible problem for our patients because they also need to go on dialysis. And from hypertension, they often go into hypotension. And there again, once these patients have such cardiac disease, they can't go on to transplant. They're not acceptable for transplant.
Thank you. Thank you so much, sir. In fact, I'm wondering if Dr. Upendra Kaur from Delhi has joined. Dr. Biradar, has he?
Not at joined, sir. He will be joining shortly, if at all, if time permits. He is in other meeting. You can go
Oh,
ahead with the.
yeah, okay.
Then,
Okay. In fact, a couple of questions we have here from the audience. One important question from Dr. Meenakshi Sahapati. How significant is the finding of diastolic dysfunction grade 2 in asymptomatic hypertensive patients? Dr. Manoria, would like to comment on this?
Grade 1 in elderly patient may be treated as a normal phenomena, but
Yeah.
grade 2 is not normal. Grade 2 is abnormal. Patient will have shortness of breath on exercise. You should treat it, whatever is the cause, hypertension being the commonest cause.
Fair. That's important consideration. Also, would you like to comment on this heart rate? How much do you think should be reduced to? And what is your ballpark figure? And how do you want to suggest monitoring for such patients?
See, there is ample evidence that increased heart rate is associated with increased morbidity and mortality. Even in controlled hypertensive, your heart rate is higher. Various trials have shown that you are at higher risk of cardiovascular events. But we do not have any randomized controlled trial which has shown that you decrease heart rate from 80 to 70, there's the benefit. So this is a desirable goal, but this is not a guideline-based recommendation. And if you are using beta blockers for hypertension or some of the coexisting abnormalities, the heart rate will automatically. But we don't have any guideline-based recommendation. The effect is definite and certain, but trial is yet lacking that you lower heart rate, you decrease all these events. That is the problem.
Okay, I want to ask you a practical question, sir. In case you want to add a first drug, will it be a beta blocker? If you want to add a second drug, will it be a beta blocker? If you want to add third drug, will it be a beta blocker? What is your personal approach?
All selection of all these 4 drugs which has come on number 1, it depends on the subset of the patient. We often find young individuals who have isolated systolic hypertension. They are usually IT workers. They don't sleep at night. It is beta blocker which control their hypertension. All these other drugs, RAS blockers or other diuretics don't control them well. So all depends on the subset of patient. If it is an elderly, we like to use a calcium channel blocker and diuretics. In a younger patient, RAS blocker, and if necessary, a calcium channel blocker, or if there's some concomitant problem, even a beta blocker. So all depends on, there's no that this drug has to be used number 1, 2, or other so number 1. So it all depends on the subset of the patient.
Fair enough. So in other words, so when we are looking at the patient as a whole, we will have some fair idea how we would like to deal with the patient's opinion or other condition and prescribe the drugs. Now, there was concern about the so-called office BP not being reflective of actual BP of the patient, and out of office blood pressure should be measured. What is your approach in your practice that you have been following? Just could you elaborate for the benefit of all the listeners, how you would like to follow your patients?
So sometimes the office BP blood pressure may be higher than the home, what we term as white coat hypertension. Or paradoxically, the home BP may be higher and the office BP may be normal. And this we suspect, suppose somebody has a target organ damage and his blood pressure is normal in the office, what is termed as masked hypertension. That's why we say at least once in a time you should have a ambulatory BP monitoring so that you can have a pattern of the hypertension, a circadian rhythm of the hypertension in that particular patient. Because if you are looking only at the office BP, you will be missing masked hypertension. So both these subsets, they demand either you solve this problem by repeated home blood pressure monitoring or by an ambulatory monitoring if possible. So that is important.
Yeah, in fact, we also have published this data when we measure the blood pressure out of office in a separate room in a quiet atmosphere that Dr. Kripalani was pointing out. There is something like a 20/10 drop of blood pressure within the next about half an hour or so when the patient is waiting in the waiting rooms. Do you recommend having such practices in India too, if it is possible?
Very difficult in the OPDs with so much rush. very difficult to adopt this measuring blood pressure 3 times by the automatic and a separate room. I think very difficult practice because the number of patients are so many. But if there is a selected subset of patients, we can resort to, but cannot be done for all. Difficult, at least in the OPDs.
At
Yes.
the moment, the
Sir, may I
practical-
say something, sir?
Yeah, go ahead, please.
See, the one that we use most is now the home BP. Educated patients, even uneducated patients, if we put enough effort into educating them, then a lot of of course, the nocturnal hypertension will not be visible. But the masked home hypertension will definitely be visible. And if we teach the patient to check twice a day, morning, the worst hypertension is just before waking up. So the morning, early morning, before he goes to toilet or after finishing comes back, first thing in the morning, check pressure. And again before sleeping, just twice. A fair idea comes, and we have some data of ours also, because that's the only real way to reach all the patients. Even keeping these instruments, which I have in my office all the time, is a specialized thing. It's difficult, it's no time, but as a specialized hypertension and CKD specialist, I think every CKD doctor, treating doctor of CKD patient, nephrologist, should have these instruments. As against that, a general practitioner can't have it. MD physician certainly should try to adopt if it's possible, but home BP is the way to go in these cases. And a long term, with millions affected, with a home BP, especially if you use the one which gives 3, average of 3, that MicroLife has got. It gives an excellent, within half a minute, you tell the patient, and it's much better. It picks up a smaller reading always. Sometimes, of course, it won't pick up masked hypertension. It won't pick up the night pressure. So for
Excellent.
us, I think every nephrologist should do it. That's my answer.
A very profound, proponent of home blood pressure reading and out of office blood pressure reading being obtained in patients. And it is indeed a kind of a changing scenario in the next about few years' time. I think that the practice should be percolating into the physicians' offices also, with physicians would be already crowded by consultation hours with quite a few patients. In other words, nurse educators or a technician sitting outside of the doctor's offices could also contribute to the care of the patient. While diabetologists do a good job, cardiologists seem to be still lacking behind it. In fact, it is a very interesting point for us to deliberate when we talk of home blood pressure reading. What should be the ideal readings of blood pressure? As Dr. Kriplani was mentioning, morning blood pressure as soon as the patient gets up. And the second blood pressure readings should be obtained just before the patient retires to the bed. And of course, 3 readings, some people recommend 2 readings, and the appropriate method should be adopted. I'm glad that that has been brought out. That is the only way to assess white coat hypertension as well as masked hypertension. That's what Dr. Manoria was mentioning about. If Dr. Kaul is there, because we are already kind of reaching the end of...
No, sir, he has not joined. We can go ahead. Yeah.
Oh, okay. Any other parting message, Dr. Manoria, for the audience? Because we are left with 3 minutes now.
The message of World Heart Day is very, very clear. That has been repeatedly stressed.
Yes. Okay.
Dr. Manoria, may I also say that obstructive sleep apnea is a very big problem, and the more we correct it, the better it will be.
Yes.
I'm glad, very happy to kind of hear that comment from Dr. Kriplani again, indicating that sleep is an important part of the
and hypothyroidism.
And also hypertension, where it can be,
very common causes.
Yes, one of the important causes of so-called secondary hypertension that we may often miss out in our busy practice.
Even aldosteronism.
Yeah. On behalf of the faculty.
So there is one question, Dr. M. Shankar Sharma wants to know what is your opinion regarding the electronic instrument versus mercury sphygmomanometer in a setup in our country.
Yeah. Dr. Manoria, please. What is your...
Mercury is banned. The way to record blood pressure is automatic BPM. Mercury is banned, although it's being used by physician. It's banned, no longer allowed.
Yes, it should be staying away from mercury instrument as much, and it is highly desirable that we should avoid using mercury in our offices. How
Sir,
about Dr.
before you
Kripalani? Does
close,
he
can
have
I
any?
tell you something?
Yes,
One
yeah,
of my students practicing in Mofussil Place had a mercury instrument. His children picked it up and broke the tube on his bed without his knowing it. His wife cleaned it. 4 people got mercury poisoning, including the patient himself, the doctor himself. It is a documented case and is going to publish it. Mercury is no more possible. It kills people. Luckily, they did the chelation and saved the 2 children. It was the critical problem. It happened in Maharashtra. It's a true story.
Oh, I'm very, very unfortunate. I am sure the advocacy of our mercury manometer being used in the office practice should be completely abandoned, and it should occur at the level of API, IMA, and the Indian practitioners in general. And the license should not be given to the people who manufacture, mercury apparatus. That's the one of the strongest advocacies that one can have on the mercury instrument for blood pressure measurement. Okay, with the permission of the faculty of the day, Dr. Manoria, Dr. Kripalani, and that was preceded by a brilliant talk by Dr. Venkatram, emphasizing the concepts of World Hypertension Day of the day, which suggests that we should measure the blood pressure, we should treat the blood pressure very adequately, so that we live longer, and we live longer, not just to live longer, but healthy life. That is the ultimate goal of our life indeed. And the points that were brought in by Dr. Manoria in terms of the organ evaluation and the options that we have in the management of hypertension, and important inputs given by Dr. Kripalani about the management of hypertension in CKD and the calcium management in the patients with CKD and its importance and its prognosis in the cardiovascular outcome are to be appreciated. Indeed, the questions from the audience were also very interesting, bringing out the facets of care of hypertension in the present scenario. Suffice to say that we should be staying away from mercury. We should be using the office blood pressure as much, and out of office blood pressure. And home blood pressure monitoring should be routinely recommended, so that we get into the era quickly, which is contemporary already in the West. And while we select the patients, select the drugs for the patient, the drugs should be matched for the patient's requirement, as was emphasized by Dr. Manoria. Friends, we enjoyed both the talks and also critical comments by Dr. Kripalani. It is a pity that we could not get Dr. Kaul's inputs in this area, who has published on the heart rate evaluation in hypertension, published in CSI journal in our just about a couple of years ago. It could have been very interesting to listen to him. Suffice to say that we had a very fruitful day, and may I thank the organizers for providing this opportunity for all of us, especially for me. I always look forward to be associated with API crowd, because that gives us the real taste of medicine for cardiologists, because cardiologists seem to be sometimes cocooned into their practices. Thank you so much for the kind attention, and thank you one and all. Back to Dr. Biradar, please.
Thank you, sir. Thank you for that wonderful moderation, and I thank all the speakers and the faculty. Before Dr. Vishwanath proposes a vote of thanks, I request Dr. Vishwanath to propose a vote of thanks. Kindly unmute and speak. You are not audible, Vishwanath.
Yeah, now you're audible.
Yeah, sorry. Good evening, sir. Thank you one and all for this excellent session. To begin with, all the speakers, Dr. Professor Venkatram, an excellent lecture. Dr. Manoria, sir, a brilliant lecture. Lot of valuable take-home messages, simple things like LVH with dilatation, LVH with fibrosis, flow velocities. These are the things which really help physicians a lot, I feel. I think thank you for that excellent lecture. And Dr. Kuplani sir, also thank you very much for your inputs. And as usual, a very crisp and great moderation from Dr. Nagaraj Desai sir. I also thank my chairman, API, and Dr. Biradar sir for bringing all these expertise and giving us valuable inputs to all the attendees. Thank you, all the delegates. Thanks also. Thank you.
Thank you, sir. Thank you, one and all. We sign off.
Good
Thank
night.
you, Dr. Kriplani, Dr. Manoria,
Good
sir.
night. Good night. Thank
Night.
you.
Thank you, sir.
Thank you. Thank you all. Bye-bye. Good night. Good night, sirs.
Good night, sir.
Night,
Thank you.
everyone.